I'm going to ask Sam to go ahead and start the first panel discussion.
Thank you, Mahesh. And so for the next half hour, I'd like to invite my co-panelists, or our panelists, Drs. Stephen Hoff, Dr. Joe McGinn, Nirav Patel, and Dr. Fran Sutter to the table there so that we can talk about less invasive coronary surgery. And one of the things that Joe McGinn and I talked about as we were getting ready to start today's lab was that coronary is back. And as much as you may have heard that coronary was dead for surgeons, it is not. It's the only thing that's going to keep us alive in the big picture, because there's percutaneous ways to take care of everything. There was a percutaneous way to take care of coronaries that has, I think, shown us it's tied, and we've survived it, and now we're coming back a little bit with more and more data regarding graft patencies and some of the important things that distinguish coronary surgery from percutaneous intervention. So I wanted to just throw up a couple of slides to kind of stimulate the discussion. I think everybody has heard of the word hybrid coronary revascularization. Usually there's some good discussion at this meeting regarding hybrid, which is an up-and-coming way to perform multi-vessel revascularization in patients without sternal incisions. So if you do a Lima LAD bypass, whether you do it with the robot or not, you use a sternal sparing approach, and then you do a PCI for a non-LAD lesion. That's called a hybrid revascularization. If you do it staged, it's hybrid. If you do it simultaneous, it's hybrid. It can be done for two reasons, really. For low-risk patients who have low syntax scores in non-LAD targets who are amenable to a drug-eluting stent, or for high-risk patients where the multiple comorbidities dictate that avoiding a sternotomy is the best way to go. And there are many iterations of this, and I think our panelists, hopefully, who have a lot of experience in this approach, between the four gentlemen sitting at that table, there's thousands of hybrid surgeries that have been done, and these are some of the benefits of doing the surgery first. These are some of the benefits of doing the PCI first, and you can read them, and we'll hopefully have a good discussion of that. And then this is some of the benefits of doing the PCI and the surgery in one session. The benefits of hybrid revascularization as a whole has been pretty much documented in many publications, with low mortality, shorter hospital stays, zero deep sternal wound infections, and a slightly higher intervention rate at midterm than CABG, but definitely lower than for multivessel PCI. So I'm going to start with this case really, really quick. This is a 59-year-old executive that showed up to our hospital at the University of Chicago in January of 2013, and the month is extremely important because I started at that hospital in July of 2013. Executive, he's got sternal wires there, not because he had previous CABG, but because he had a previous sternotomy for a thymus operation, thymectomy. And you can see he's got severe three-vessel coronary artery disease involving all three territories, and normally most people would want to do an open coronary bypass, I would think. What do the panelists think about this gentleman? 59-year-old executive, a very healthy guy, and has a previous set of sternal wires for a thymectomy in the past.
Diabetic, non-diabetic?
Non-diabetic. Non-obese, the usual risk factors.
Did he get radiation for his thymus, or?
No radiation. It was a benign thymic tumor. You don't have to do an elaborate thing. I would just shout out what you would do. You can start with Steve and work down.
So I think that multiple options exist. His sternotomy doesn't bother me. His pericardial space is intact. So I think that with that we lose, presumably, with that we lose none of the options that you've just mentioned. I mean, I think he can have a transsternal operation with whatever you happen to do best. I think that given the look of his type A lesions, he's got probably low syntax multivessel disease, and theoretically minimally invasive mammary of the LAD and stents to his non-LAD targets is not an unreasonable option if the thought of opening his sternum is unappealing to either the surgeon or the patient or his referring cardiologist. So I think he's got all the options.
Okay.
Pretty much the same. I talked, well, first, the right coronary, I don't know whether it's large proximally and small distal, that there would be a stent. Anyway, I talk to the stent doctors and say, what can you do for this guy? And they would tell me, and then I would say to the patient they could do, I don't remember what the LAD would look like either, but
Oh, I'll play it back.
they all could be stented. At least the circumflex can be stented easy, and the right probably can be stented easy.
There's your LAD.
The LAD looks rotten up top. So I would talk to the stent doctors, and if they could stent the circ and the right, and they thought they would get a good result, then I would offer the patient either sternotomy or, but you know, like you said, it's a low syntax store. This patient really could do very well, maybe even with stents, but I think that looks a little complex in the LAD.
The LAD has an osteal lesion that shows up on the
I
spider
didn't see
view
that.
here as well.
Okay, so for sure,
Yeah.
it gets a mammary.
Okay. Joe?
Yeah, I would, first of all, I've done a case like this actually recently, a thymectomy patient with a sternotomy, and I did do a mixed cabbage on the patient, and it turned out to be a lot easier than I thought it was going to be because the intrapericardial space was not violated. There were some adhesions in the left chest, but nothing really limiting. In this particular guy, I think he deserves bilateral mammaries, a young guy like this, and I would also look at each individual artery to see which one can be stented easily and with a very low recurrence rate. And just looking at one or two of them, they look like there are several arteries that can be stented very easily and probably should be rather than using a vein. So my strategy might be to do a mammary to the LAD, a lima to the LAD, and a rema to the OM or that ramus, and let them stent the other two vessels. So I think that might be a good strategy for someone his age.
Okay. And Nirav?
So I think my worry is the right. If you see there's a CTO, I think what we are seeing, the small little vessels are probably acute margin of arteries. And there is a late filling ghost, which probably becomes the PDA. So what I would do is I would offer him open cabbage with a lima to LAD, rema to OM, bilateral mammaries, and if he does not want a full sternotomy, then I will ask if we are doing a hybrid, then I would ask the interventionalist to go first. And I want to see if they get good result on the RCA and the OM, and then we do the lima to LAD. I would not go lima first.
So 2 are kind of leaning towards sternotomy, and 2 are saying they would do a combo or a hybrid.
It's a discussion with the patient.
Yeah.
It's like, you know, if the stent doctors could do the LAD easy, then it wouldn't even be a discussion. But I think each patient needs to know the options.
Okay. So what happened was, this is before I showed up on the scene, and this man, because he's a high-powered executive, decided he did not want to have surgery. The only surgery that was being offered was a sternotomy operation, or in his case, a re-sternotomy. And so he had multi-vessel stenting. And this is the,
The CTO.
yeah, it's the result of the CTO.
That's
It's a
why
massive
it's
right
good
coronary.
result. Yeah, I was.
Young guy, reasonably good result, asymptomatic, went back to work a couple days later. He reappeared about 5 years later,
You knew that was going to happen.
as you might imagine,
No surprise there.
and he had symptoms, and this was his angiogram.
Stents did well.
So his circ stent is working well. His RCA seems to be in good shape, but his LAD is now restenosed. So they fixed it again. So we were never called for this patient on the second time around. We were called the first time around. So I bring that case up just to show that interventional cardiology is very advanced. And for us to continue to be relevant in whatever space it is in cardiac surgery, we really have to be there. and we have to have the conversation. We have to be in touch with the interventional cardiologist and collaborate with them. And I kind of totally agree with the responses from the panel, and I think the message that comes out is I would talk to the stentologist and talk to the interventional cardiologist and try to customize the therapy for each artery. And if I had been consulted on the original one, I would have said exactly as Fran and Nirav and Steve and Joe said, is what can you stent, and let me put mammaries on the rest. And so that's not just a hybrid, it's an advanced hybrid when you're using two internal mammary arteries. I'm going to throw this up for discussion for the panel. This is the Society of Thoracic Surgeons guidelines on arterial conduits. The ITA should be used to bypass the LAD, level of evidence B, and as an adjunct, a second arterial graft should be used. Now, the use of arterial grafts in the STS database is pathetically low. It's well under 10%. And I kind of want to poll the panel as to, do you think that bilateral ITA is something that is consistent with minimally invasive coronary surgery? Should it be? Should it not? Is the benefit of saving the sternum adequate to not do bilateral IMAs, or is there another way to go? I can start from Nirav on the other side.
So bilateral IMA obviously is beneficial. I personally don't do many bilateral mammaries in a minimally invasive setting. I do about 65% of my patients, if they are eligible, younger age, below 70, good life expectancy, and non-morbidly obese, and I do diabetics. My cutoff is hemoglobin A1C below 8.5, then I will do betas in sternotomy cases. Minimally invasive, I particularly don't do many bilateral mammaries. I do Lima to LAD, and then Rima I would harvest robotically to go to the high diagonal or maybe some ramuses. My issue for that particular operation is that I think I just haven't made myself enough comfortable and consistent to do the lateral wall grafting in a minimally invasive setting. I'm comfortable doing them on a beating heart in a sternotomy or a rested heart, whichever way I want to do it. So minimally invasive bilateral mammaries maybe would be doable if we get consistency, and I think connectors would be the answer to that, in my opinion.
I'm not sure what you're asking, but if you ask my opinion and it was me getting the surgery, I would like to have bilateral mammaries. I think that the reality is that it's very difficult to show a difference between bilateral mammaries and a single mammary case, and we've been struggling to show that difference, but it's intuitive to me that a right mammary is going to last longer than a vein graft, and I would assume that more grafts open is going to keep me alive longer. But again, it's going to be very difficult to show.
I guess the question should have been, how do you reconcile that with the results of the ARCH trial? That was part of the question that I forgot to ask.
Yeah.
So given what we see from the ARCH trial, do we still need to insist on bilateral IMAs?
I will just make a comment, and this is not something that's unique to our field, but there's been several articles that infer that minimally invasive harvest veins are not as good as veins that are harvest open, but yet nobody does open veins anymore. And I think that the reality is it's pretty intuitive that bilateral mammaries is probably better for patients. It's just going to be very hard to prove.
Graham?
I think bilateral mammaries are better than anything else. But, it depends on the patient, it depends on the diabetes, it depends on how much they weigh. Depends, to do them minimally invasive is, I can't get to the back wall as well as maybe Joe can, but it's not hard to take them down robotically. I mean, ideally, it would be great to take them down with the robot, which makes it more difficult with your operation, Joe, but then you can expose the high takeoff marginals or even up to middle marginals. So I think that would be the aim, but I have done high takeoff marginals, but difficult. And I don't know, maybe 10% of what I do are Rima Limas. Most of them are, you do radial T-grafts if I have to do more than one.
Steve?
I would suggest that BEMAs, unfortunately, as you have just mentioned, the STS database confirms is still in the hands of a few BEMA zealots. My personal opinion is I wouldn't let the sternum get in the way of offering BEMAs as a benefit for patients. And I'm a minimally invasive zealot. I think that anything that so now we've just established that BEMAs are a highly unusual practice pattern in the United States and beyond from the STS database. Everything that gets done minimally invasively is now an order of magnitude more difficult. And so now you're talking about an operation that people don't want to do for whatever reason, even though we think there's benefit, especially in selected patient populations, and you're making it even more difficult minimally invasively. So I think that that will be left in the hands of a very, very few highly skilled technicians, but will probably may never be a more commonplace operation. If it becomes more commonplace transsternally, then it's incumbent upon those of us that are minimally invasive advocates to find a way to train that. But right now, I'd say it's out of reach.
Yeah. I mean, one of the reasons that BEMA is not used is for the fear of sternal wound infection. And so if there are a way to eliminate that, which I think sternal sparing is, then having the ability to do Joe's operation with 2 mammaries would be rocket fuel for our specialty, you know, in terms of sparing the sternum, taking down 2 mammaries, and having pretty much, you know, the best of all the worlds. Okay, so I had some points for discussion, and we can include, oh, here we got, I'm sorry, go ahead.
2 questions, actually. I think it's more of a comment. So our trial, I think, is just only a 5-year outcome, and I think we want 10 years.
We have 10 years on. Yeah.
Still waiting on 15 years before maybe you'll see a larger benefit from, you know, bilateral mammaries. Then with respect to sternal wound infections, I think, you know, skeletonization has shown that there are increased incidence of SWI. But for betas, especially like a minimally invasive setting, what are your strategies in terms of, you know, the configuration? Is it always, you know, you use a beta to the LAD and then use your beta to lateral wall, or do you root the REMA behind, you know, the transfer sinus and use that for the lateral wall and not sacrifice, you know, a proven standard old technique with, you know, the beta to the LAD?
You want to take that?
I would suggest that just like everything else we've talked about, it's what you're comfortable doing transsternally and then just moving it to a smaller incision. So if you use skeletonized BEMAs to go and put them across the midline somehow, then, you know, that's can be done minimally invasively, and, you know, some of the super users on this panel have done that. Again, my personal opinion is that's going to probably, for the foreseeable future, be in the hands of some extremely skilled zealots and not a part of mainstream surgical technique.
So getting on to some of these topics here, just so we can cover a broad range of things. Joe, could you talk a little bit about your pre-op evaluation for a mixed patient? Is there anything special that you do that you wouldn't do, say, for a sternotomy in terms of working them up?
Yeah, I think the biggest thing for me is the angiogram, the catheterization. I want to make sure that I have good, solid distals, and I'm not having to do 6 bypasses. That's probably one of the big times I'll eliminate someone from having a mixed surgery. And the other one is obesity. Mm-hmm. That is a big problem. The whole concept behind the mixed CABG as I do it is to bring the target artery into the incision so that you can use a regular needle holder or regular pickups to create the difficult distal anastomosis with your best dexterity. If you have 3 inches of fat between you and the target, then you're using longer instruments, you're further away from the target, and your dexterity just gets diminished. So I think obesity is a big problem. And then lastly, peripheral vascular disease. My bailout strategy when I first started doing this was to convert to a sternotomy. My bailout strategy now is to cannulate the groin or do peripheral cannulation. So I need to know that I have that option available in the femoral artery. So that is, on occasion, something that would persuade me away from doing a minimally invasive case.
And how do you evaluate them, Joe?
I just send them for peripheral studies, Doppler and plethysmography.
So no CT scans or CTAs like you do for the
I don't do anything
mitral?
fancy, no.
Okay. Do you ever do a CT scan of the chest and exclude somebody based on that?
No.
Never. No depth of subcutaneous tissue or distance between posterior sternal table and LAD
Nope.
phases you?
The thing I do most is I'll literally lay a patient down on the table, on their bed as I examine them and try and see if that stretches out and feel between the ribs and see if it looks like it's going to be a good case for that. But I don't really do anything more from an imaging standpoint to evaluate whether it's a good case for mix or not.
Okay. Intolerance of single lung ventilation. Fran, what do you do when you basically drop the left lung, you're getting ready to take down the mammary, and the hypoxia starts, and the anesthesiologist starts talking about CO2?
Well, what I used to do is have the anesthesiologist put some PEEP on the left lung. But we don't drop the left lung until I'm ready to do my anastomosis. I just have them ventilate, and the CO2 in the chest keeps the lung out of the way, and the only time the lung will come up in your way is like when you're have a thoracotomy. So the CO2 keeps it out of the field. Rarely does it not keep it out of the field.
So when
Then you don't have to listen to the anesthesiologist, complaining that the SAT is 90% and they have to do something.
So you don't drop the lung until you make your mini thoracotomy?
Nope.
And do you drop,
It's so safer when you're putting in the ports, you have the lung there versus just the heart there. It's better to poke the lung than the heart.
And so is it a double lumen tube or a single lumen with a bronchial blocker?
Most of the time they use a bronchial blocker.
So they stop the breathing while you put your ports in, I assume?
Yes,
They
we
stop-
totally disconnect and
Connect,
put a Varius needle,
Yep.
10 a PEEP, push everything over, then put the port
Then
in.
put the ports. But you don't maintain any kind of blocker while you're taking down the mammary. The left lung
And
stays
they have
away.
it poised that if you really need it, they can blow it up. But
That's a very interesting thing that not many people know, is that you can maintain a space above which you can put your instruments through, you can take the mammary down, you can see what you need to see on the top, and the left lung is continuing to breathe. When I first started doing robotic Lima takedowns, we would always drop the left lung, and then I learned that, well, hey, you can actually have it be breathing and still not be in the way. And now we do that for the TCABs as well when they don't tolerate it. And I think it might lead to earlier extubations and less lung problems when you don't keep that one lung down for a long time. Anybody else have any comments about lung management during?
Yeah, I do. Since I put the lung down right from the beginning of the case, I've run into this issue quite frequently. And we have an algorithm that we go through. First, we'll put PEEP on the up lung, which sometimes actually does the opposite, because if you increase the pressure inside that right chest, you can force more blood to the down lung, which would then worsen your desaturation. So I only try that for a short period of time. It doesn't do anything. What makes it worse, we abort that, and then we'll put CPAP on the down lung. Usually run about 7.5 of CPAP. That's usually enough to override any problems with saturation. On a rare occasion, I cannot achieve a good saturation with CPAP up to 10 on the down lung, and then I'll go to 2 lung ventilation with very, very low tidal volumes. I'm talking like 350 cc's of tidal volumes for both lungs, and pack the left lung with a couple of lap pads. And I just really have not had a case where that did not work. So that's my kind of algorithm for hypoxemia with 1 lung ventilation.
Any other tricks
Well,
of the trade?
I dropped the left lung for my IMA harvesting. Everything, it's a little bit easier. But I have no problems. What Joe suggested, if there is any issues, we have the same algorithm, start some CPAP on the left lung. If it does not come up, then 350 cc bilateral lung ventilation, higher on the CO2 on the left side, and that usually resolves the problem.
Lima injury. Steve, you're up. Not that this has ever happened to any of us. But.
Yeah, I've never had one. I don't know how about you.
Is it a cause for conversion to sternotomy?
I would have a low threshold for that, sure. I mean, it depends on the Lima injury. Can the Lima be repaired? Yes. Could the Lima be anastomosed in another way? Yeah. Could it be used as an interposition graft, or theoretically, even in the minimally invasive setting, as a free graft? The answer is yes. But I think, again, that's a technique for someone who's done a lot of them. And so I would have a very low threshold for converting that patient to maintain the benefits of Lima.
Joe?
Listen, I think we all have to be honest here, and I think the reality is that if you take a patient into the operating room and they come out without a viable memory artery to the LAD, that's a problem. So you got to do whatever you can do within your skill level. And I agree with Steve. There are certainly, and we do see every now and again this memory that you're harvesting, and all of a sudden the whole thing turns purple right from the beginning to the end and is not usable. That's a reason to move and get the right memory onto the LAD. So whatever your comfort level to get that right memory onto the LAD, that's something we have to do. Under rare exceptions, I would say if you have an 80-something-year-old person who's got a million medical problems and you really just want to get in and get out, you could probably justify putting a vein graft or some other conduit on there. But by and large, I think leaving the operating room without a memory to the LAD is a problem.
Fran?
I think, so 1.5% of all my patients are conversions, and 75% of the conversions were because I screwed up the mammary. So, and then usually that was because of inadequate tactility, and I actually took down the mammary looked great, was ready to sew, and it doesn't work. So that's most of the mammaries. So in the meantime, when I really screw up a mammary that's non-fixable, I'll just go across and get the REMA, because that's the operation. It's pretty easy to go across and get the REMA. But I have, as recently as 2 weeks ago, you make a small thoracotomy, I wrecked it up here, and I put it back together. But most of the time, I would say I go across and get
the REMA.
The operation is a mammary.
And
It depends. It depends on, if you think the patient's ever going to have a repeat surgery for any reason. You sort of worry about doing that across, but you just weigh a lot of factors.
And so early in somebody's minimally invasive approach, you probably recommend that they convert to a sternotomy just to be safe and to get that. Okay, so I think we have about 3.5 minutes, and I want to spend it mostly on graft patency assessment intraoperatively. So if each of you, and I think what we're really talking about is measuring flows versus doing angiography, and then if you do measure flows, what are your criteria to revise a graft, and what do the flows mean, and how do you interpret them? So we'll start off from Steve and then work our way down.
So early in my career, we used Medistim for every case, developed a large database, and never really did anything with it, and nobody ever made decisions other than the runoff that you could see at arteriogram that Medistim changed, and so we stopped doing it. So we didn't use a non-invasive approach. When I started doing mid-cab, we did insist that the mammary patency was the #1 thing, and we did on-table arteriograms for everybody, and we have reported that. And we reported that as part of the learning curve that goes along with minimally invasive coronary surgery. The problem was we were finding things that nobody had ever really seen or looked for before. We were finding tremendous graft spasm, anastomotic spasm. While it took a lot of patients back 48 hours post-op because we were worried about things. They looked beautiful at 48 hours. We've probably been doing this for 40 years and never really seen this before. So after the first 50 cases we did, the cardiologist came to us and said, we think that the risk of an arteriogram is higher than the benefit. Can we stop doing this during hybrid?
And this is at Vanderbilt. This is at Vanderbilt where you guys were doing angiograms for sternotomy cases.
Correct.
Right.
Yeah. And so we basically then stopped looking at them. But we learned a lot about some of the things you find, the things that are important, and things that are ultimately reversible, and the learning curve that goes along with minimally invasive coronary surgery.
So would you recommend that we do coronary angiography on immediately intra-op for?
I think there's a role potentially in the learning curve of someone who's starting to do minimally invasive coronary surgery. I would not recommend it in the across practices, as it is not a part of coronary practice transdernally.
Fran?
I think it's mandatory with any beating heart surgery, whether it's open or otherwise, to verify that you have great flow, whether it's an arteriogram or using the flow gadget. And then you have to assess the flow in whatever artery depending on the runoff. If you have a 99% osteo-LAD and it's gargantuan heart, you'd expect to have big flow. I also very much depend on the sound that it's great diastolic flow, because sometimes you can have adequate numbers but the diastolic flow is inadequate. Now, you really have to assess all the different parameters with the graft patency, but one of the reasons that beating heart surgery did not take is because it was not mandated that you use a flow probe or do an arteriogram to check your grafts. If any study had a flow gadget in there, everybody might be doing beating heart surgery is what I think. Okay, that's my little thing.
So I do a Medistim on everybody, on every graft, and I just don't think what I'm going to tell you, the reason why makes any sense, but I'm going to do it anyway. I like to go home feeling good about what I did. And when I see those flows like that, it just makes me feel like I can go home and sleep comfortably at night. I also do send it out on my op report so that if anybody does want to know, what's going on with each of the individual grafts, they have it. But the reality is if I have a 1 millimeter coronary that's very diseased and I'm struggling to do an anastomosis and I get weak flows in it, I don't really know that I can take it down and do better because that's just a crappy little artery and it's probably going to have crappy little flows. So I really have not changed my approach. I've not redone anastomosis based on that. And the one time recently when I had a graft fail, the flow was great in it at the end of the case.
So revising your anastomosis is not connected to a certain number of cc's per minute or diastolic index
Yes.
or
I will
pulsatility
tell you
index?
one thing, that there's a learning curve to use the Medistim device. So for instance, I occlude the coronary with a vessel loop, do my anastomosis, and check the flow before I unocclude the coronary. So the competitive flow is not an issue. And if I don't get good PI with the proximal coronary occluded, then there's obviously an issue. But I just haven't seen it. But I've learned that if you take that off and you have competitive flow, your PI could be 10,
Yep.
and it really doesn't mean anything because it is truly competitive flow.
So you can't make it better. You're up?
So I agree with Joe that I always, even though I don't occlude the vessel all the time, I always use a shunt. I do assess my Medistim flow with saddle loop retractor tape up to assess for competitive flow. What has helped me in the recent, because our cardiologists are now big FFR heavy, and so those kind of questionable lesions, even though I always think that is the lima going to take, this is like 60% lesion, I can tell you if FFR is positive, there's a large distribution of the vessel, and you do a lima duality, measure a Medistim flow, you can see a huge diastolic flow. So I think FFR is a real thing. I'm not yet 100% convinced about IFR yet.
Yeah.
The case which I did last week, there was a lot of competitive flow, and they said IFR was significant. It was, and the lesion was 70%, maybe 60-70% prox LAD.
Does everybody know what he's talking about when he says FFR and IFR? So functional or fractional flow reserve, and what's the IFR? I think instantaneous flow.
Instantaneous. The only difference is now they are getting lazy and want to do IFR because you don't have to give adenosine.
Exactly.
So I don't think IFR is clinical setting. The cardiologists always design a trial in such a way that they can show that something is important. And that's why I say, somebody mentioned the ARTS trial. If cardiologists were doing the ARTS trial, they would have done with 50% of those patients and showed beta is better than zeta by showing angiogram in every patient and showing patency. Mm-hmm. There is no trial in the stent literature with the advancement of all these first, second, third generation stents which shows any mortality or MI benefit. They only look at patency. So if something is patent longer, has to be better intuitively.
Right. By definition.
Because mortality depends upon a lot of other factors, and that's why ARTS trial failed.
So since you bring it up, just as a last closing comment on the coronary side of this, do you think FFR-directed coronary bypass is going to be a thing? Is that something that you think is going to be beneficial to patients, or as they do now, FFR-directed stenting, or is that something that is just going to not be important for us to know?
The only manuscript which has come out very recently is not about FFR-guided CABG. It's a small number, 45 patients, and I don't think that has given us all the answer. But I think I'm getting to like the FFR more because those LAD borderline lesions are FFR positive. yesterday we did, just before I came, we did this case. It was a cardiologist, referring cardiologist. We did a Lima to LAD as a hybrid, two vessel disease. His OM was not FFR'd. We FFR'd it. It was negative. He actually got single vessel grafting. So I think they are doing less OMs, but it's kind of very strange that LAD, the borderline lesions are of FFR positive, whereas the distal OM1s and OM2 and PDAs, they are significant lesion. They could become FFR negative because probably they're not having that much distribution.
Yeah, I think it'll allow us to do less invasive surgery on more people, and it will also help us cut down on the number of failed grafts long-term from competitive flow.
100% agree.
Any questions from the audience? Thank you very much.
Thank you.